So the last talk I have here is it was entitled "The Future in Medicine," and I sort of took a different spin on it. And I said, well, let's talk about the future and the past of medicine, because I actually think that it's super important to learn from the past. And I think that what you guys are about to embark on is just really crazy, right? What I want to do is sort of paint the picture of how far we've come in medicine, particularly in the last 200 years. Because it's truly incredible to think about, right? So you think about like all the history of humankind and back to ancient times when people were doing surgeries and were expelling, divine displeasures from people's body by letting them leach out or making holes in people's brains without any real understanding of what was going on. I'm telling you, I think what you're going to look back at is to think around and say, wow, in 2022, we actually had no idea what was going on. Because when we look back and we say what we're going to be doing in 2050, and we realize that, let's say we were treating cancer with chemotherapy, which is a baseball bat for just whacking all the cells in the body, we're going to be like, what the hell were they thinking? Why were they doing that? Just like we think back to the 5th century or anything, and they're like, wow, they were making holes in people's skulls to just get out evil spirits, which is what they were doing. So I'm going to try to take you through a little spectrum of this to give you a little understanding of the history of medicine and where we've come, right? So some of the oldest collections of medical writing, Eber's Papyrus, this is back in the day, covered about 200 medical diseases, right? And then the real birth of modern medicine, right? The father of modern medicine, Hippocrates, right? He was one of the first people to say, hey, it's not just about like evil spirits that a body is going wrong. Let's look for natural causes. Maybe a healthy lifestyle and not just the gods raining down punishment is causing people to either be healthy or unhealthy, right? This is Galen. Galen was a 2nd century physician and one of the early anatomists, right? He was one of the first people to describe arteries and veins, but he thought that all these things were, basically that disease was an imbalance of maybe the humors of the body, right? And so some of what he did was a lot of bleeding people out and getting rid of the bad humors in order to control them. But he was one of the early people thinking through like, hey, what if I dissect an animal and see what's in there? Back in the day, dissecting a human was very, very no-go, right? Like you could not do that. That was considered just asinine to think that you would take a dead body and look at it and study it, right? He was doing all this without ever actually having studied the body. And then others later on, like Vesalius, actually did study the body and were able to understand a little bit more about the anatomy. And every single juncture of this, you get back to looking at maybe the previous 100 years, 200 years, 2,000 years, and the person who's studying it saying, wow, what were they doing before then? Like this made no sense. Why were we doing this? This is obviously completely different. We look at Vesalius' work and we think the same thing. We think back and say, wow, what was he thinking? He didn't know what he was doing. But the reality is he was making a lot of progress, right? Everybody is making progress as we move on. So we went, for centuries thinking that disease was just this divine displeasure to now thinking through a little bit more about what might cause disease. And it's really only in the last 200 years or so that we've made any real true progress in this. And what I want to convince you of is that you guys in this room who are the future doctors, in the next 50 years, in the next 100 years, maybe your kids, are going to like blow all this out of the water, right? We're going to think through and look at the way that we do things today as completely barbaric 100 years from now. And just think about how much progress we've made in the last 200 years dealing with this. And that's what I want to take you through, right? 1812, average life expectancy is about 40 years, right? Modern sanitation, modern medicine, modern health have obviously extended that a lot, particularly in first world countries. Not so much, by the way, in third world countries, but in first world countries they have. So I want to take you through a couple of the advances in just the last 200 years in cancer, the tools of the trade, and modern surgery, just to give you some perspective. There's hundreds of these examples, but here's a couple, right? Let's talk about modern surgery. Anybody know what this painting is depicting? Any art history majors in here? I bet you art history is a good way to get a 4.0 GPA.
No, it's not.
Maybe it's not. So this picture is depicting the first use of anesthesia ever, right? So before, basically this was a dentist, I believe he was in Boston, Morton, who realized that ether had properties of amnesia and pain relief. Before this, the way surgery was done was you got the patient inebriated, you held them down, and you worked as fast as possible to do whatever you had to do, right? Cut off their limb, tie off whatever, dissect out a cancer. But modern anesthesia, and particularly ether, was such a breakthrough in what we can do. And this is only the 1840s, right? About 150 years ago, 200 years ago. Finally, there was a way to potentially do surgery without the patient screaming and moving and everything else, and that expanded our reach of what we could do so much, right? And this was almost like, this was a dentist who was experimenting and had to convince a physician to say, hey, you should use this, you should try to use this. And thereafter, we make such great advances, right? So William Morton, 1846, first used ether. And even anesthesia, if you think about anesthesia, it was super unsafe for many, many years, right? Up until probably about 10, 15 years ago, maybe 20 years ago, undergoing anesthesia was the more dangerous thing than undergoing surgery, right? 1 in 500 people may not wake up from anesthesia about 20 years ago. Now that number is 1 in 250,000. It's an extremely, extremely rare event that modern anesthesia causes any complications. But back in the day, obviously it was very, very prevalent. And so once we get anesthesia, now we start getting like, okay, what can we do, right? So back in the day, professors and doctors didn't perform surgery. It was barbers who performed surgery. They had the sharp tools. They had things to cut hair. They had the knives to cut off limbs. So surgery was considered a barbaric profession and not part of medicine for hundreds of years until we came around to being able to experiment and do things a little bit more advanced. Again, just a couple hundred years ago, not very long ago, that were we able to do that. And thinking back through, our study of medicine, medical students weren't allowed to study anatomy, right? They weren't allowed to do dissections. The ones who did were robbing graveyards to go get bodies to actually be able to study. So to make advances, you actually had to sort of break the law or do things that were very controversial at that time. But even then, so we get the concept of anesthesia, and so we can push further in surgery. People are still dying in droves, right? Why are people dying in droves at that point? Anybody have any ideas? Infection. There was no concept of infection at that time. People thought that was just sort of, it came about. Not that one could pass it on to another person, right? And so it was only in the 1800s that somebody even put together, hey, if you washed your hands before delivering a baby, the mom didn't die of purple fever. That was Semmelweis. And he figured this out, but actually he didn't get much credit for it because he didn't publish it appropriately. And so it wasn't until really the late 1800s that the concept of infection even came out. This is a pretty famous painting. This is Agnew Clinic by Thomas Eakins, right? This is showing a surgery, but you can see a couple things, right? Nobody's masked, nobody has gloves on, people are doing the surgery. You can see that somebody's administering anesthesia, but the chances of this patient dying after the surgery are astronomical, right? Imagine doing a surgery today without washing your hands, but nobody back then knew it. It wasn't until the 1860s, again, about less than 200 years ago, where germ theory even took place, right? Louis Pasteur really kind of looked in a petri dish and was like, hey, this is interesting, growing bacteria, right? But it took years to get buy-in from anybody. Before it was all disease is born out of thin air, right? And now, look how far we've come. Now we understand the concept of antiseptic, aseptic technique in order to actually move medicine further, right? And out of this also is born crazy things. Antibiotics, less than 100 years old. Antibiotics first introduced in World War II, right? Fleming found penicillin, nobody used it until World War II. That was the first antibiotics, less than like 60 years ago. Now look how far we've come and look how far we still have to go, right? Today we have antibiotic resistant bacteria because we've probably used too many of them. We have to figure out what's next. 1954, the first organ transplant done in Boston, right? Kidney transplant between two identical twins. Person was dying of kidney failure, I did an identical twin brother, transplanted it, it finally worked. Anybody have any ideas why that finally worked as opposed to all the other previous attempts?
Similarity for the sake of the immune system, probably a lot less likely to reject somebody who,
Exactly.
for the most part, is a genetic clone.
Exactly, right? But that concept wasn't necessarily completely understood back then, right? If you sort of organ transplanted, and kidneys were the first organs to be transplanted. Why? Because they're relatively easy. Why? Because we have two of them, but we only need one of them to live. So you can kind of take one out of somebody and try to put it in somebody else. People obviously were dying of kidney disease very quick, and so they were trying to transplant these kidney organs. They would literally hook it up to the iliac artery or even the femoral down in the pelvis. Sometimes they were even left open, right? So the first organ transplant surgeries are just done where the organ is literally just sitting outside the body so that we can watch it perfuse over time. We can watch the urine being made. But what did I just say? I said it wasn't until the 1890s to 1900s that we even got the concept of like washing our hands. And in 50 years, we go to transplanting an organ. And in approximately another 50 years, anybody know who that guy is? This is the guy who got the pig heart. If you guys remember, about a year ago, we first transplanted a pig heart. We grew a heart in a pig and transplanted it into a human. How freaking crazy is that, right? Like, and the pace, right? 100 years from, I don't know what bacteria is, I don't wash my hands while doing surgery, to I am growing an organ in a pig and putting it into a human. That's incredible. Think about what's going to happen in the next 100 years, right? This is the story, right? So David Hume and Joseph Murray, they did the first operation at Peter Bent Brigham Hospital up in Boston. I pass by this every day. It's kind of cool. Eventually, we got to lung transplants. We got to understanding immunosuppressants and why patients were rejecting organs, right? Now, even today, the field of transplant medicine, transplant surgery, is not about the technical skill of taking an organ from one person and putting it in the other. That's of relative ease. It's about how do you manage that patient after? How does that patient not die from the immunocompromisation that they might get from all the immunosuppressants that they're on? So, that was like the quickest history of surgery you can get. But again, just think about how far we've come in just a little bit of time. And then I think about some of the tools that we use on an everyday basis, right? René Lancet, anybody who know who this guy is or what this guy might have invented? Stethoscope, right? Previous to this, people used auscultation, but what was the problem? Anybody have any idea what the problem was that? Who were most physicians? Male. Were there female patients? Was it wrong to put your head against somebody's bosom like that? They didn't do it. Auscultation was only done in a certain population. Male physicians were uncomfortable doing it to females. Female patients were uncomfortable having a man's head in their breasts, right? Add to that, you might sometimes not be able to hear. There's a lot of soft tissue, et cetera. And auscultation wasn't really able to be used as a tool until this guy invented the stethoscope, right? First stethoscope was essentially just a wood piece that amplified the sound. Now all of a sudden, you could hear the heart sounds, you could hear the breath sounds, you could make diagnoses. And that was only 1800s, right? So this is the first stethoscopes. Now we have more advanced ones. That's sort of a history of what the stethoscopes look like. Today, I don't use a stethoscope. I've never used a stethoscope in the last 10 years of my practice. And it's not just because of the fact that I'm an interventionalist, I'm not a cardiologist or a primary care physician. But you guys, even as if you guys go into primary care, you guys go into cardiology, you are not going to use a stethoscope like this. You're going to use a stethoscope like this. You're going to put the thing on, it's going to amplify in your AirPods. It's going to show you the EKG. Or you're going to use point of care ultrasound, right? I'm not guessing what's going on. I'm actually looking what's going on with my iPhone and an ultrasound probe. I can do an echo right at the bedside. I don't have to imagine mitral regurg. I can see mitral regurg, right? What's going to happen here is you're going to take all these things that we used to do, and it's going to be blown out of the water so quickly that tomorrow's doctors, you guys, are going to be able to do so much more than I'm able to do that was able to be done 30 years ago, that was able to be done 50 years ago. What's this? Which X-ray?
Stimulation of, dang it. That's all I can get.
This is the first X-ray ever done, right? That's the first X-ray ever done, 1895. Again, approximately 130 years ago, right? Take the advances in modern imaging, right? First X-ray to ultrasound to CT to MRI, with CT and MRI only being in the last 50 years or so. And today, we don't have to listen to you. We don't have to think about what's wrong with you. We throw you in a scanner, and I can look inside your body, and I can tell you exactly what's wrong with you, down to the millimeter of the vessel. And then I can reconstruct those vessels to help me maybe in my procedures, right? So I know exactly where your celiac axis is. I know what your problem is in the hepatic artery. I know if you have renal artery stenosis, I can stent it. And that's just today, right? This is what's going to happen tomorrow is so crazy in this, right? Functional brain MRI. All of a sudden you can see inside somebody's brain what's lighting up, what's not lighting up. Is that tumor causing a speech issue or not, right? All of these things are just incredible for what we're going to be able to do. Take, 3D printing as something that we're just at the nascent of. Imagine being able to print a prosthesis, print an organ. Instead of doing a cabbage where you have to harvest a vein from the internal mammary or the radial artery, you know what a cabbage is? We know what cabbage is? Coronary artery bypass graft, right? So people who have blockages in their heart, they need new arteries in their heart to be able to bypass the coronary arteries. Right now we take a vessel called the internal mammary most typically and hook it up. Imagine if you didn't have to do that. Imagine if you could just print a new vessel that's perfect, that's perfect and anatomically conforming to that patient's body. And then let's talk about cancer, right? Cancer is, I think, one of the biggest things, right? So cancer, we had first no conception of it. Then we had this whack it all out approach. Now we have targeted therapy, and I don't even know what's going to happen tomorrow. Let's look through it. By the way, if you guys are, I'll actually go back to this. So when we first understood what cancer was, the approach was take it all out. And by the way, that's not dissimilar sometimes to some of the surgeries we still do today. That surgery on the right, does anybody know what cancer that's for? Breast cancer. That's a radical mastectomy, right? And that's Halstead, who's the first guy who did some of the radical mastectomies. And what he was finding was, hey, I was taking out these cancers, but patients kept dying. So his answer to it was take out more cancer, right? Do more. The concept of metastases, the concept of distal cancers, the concept of targeted therapy, not even in consideration. And that was the 1800s, 1895 or so. So what's he doing? He's taking out the breast, and then he's taking out the pec, then he's going even deeper, right? It's just keep taking more and more out, but the reality is that doesn't work for everybody, right? Sidney Farber was one of the first guys to think about, hey, maybe there's something else we could do here, right? Instead of just taking it out, could we treat the cancer? And he was looking at blood cancers, particularly blood cancers in children, right? So leukemia, an extremely common cancer, or not extremely common, but a common cancer of children, that's what he was studying. And he thought, okay, there's this treatment called folic acid to help anemia, right? Anemia is low blood count. Maybe that would help people who had leukemia, or the kids who had leukemia. So he tried it. Utter failure. All the kids died faster, right? They all died faster. But he said, wait, if I use folate to stimulate and the kids are dying faster, what if I find an anti-folate? Would that suppress it? Maybe. It did. Amniopterone. First chemotherapy, really. He came up with chemotherapy with amniopterone and antifolate, which all of a sudden started killing leukemia cells. Now, these kids didn't live. They relapsed. They all relapsed. But they were living longer than they ever were before. Now, back then, people, this is the 40s, 50s, people were like, you can't treat kids with this. They're all relapsing. You're doing wrong by them. But it was progress, right? Keep in mind all the stuff I said in the past, right? The people who maybe are doing things wrong or that we look back at wrongly now, they're trying to make progress, and that's what Farber was trying to do. And now today, we have anti-cancer drugs, right? So we kept working on the therapies. We added radiation to it, methotrexate. I mean, look at this picture of methotrexate, right? When do you think this is from? Like, this looks right out of the 60s or something like that, right? We still use methotrexate today. It's crazy, but we do. But I promise you, in 20 years, you're going to look back and say, why were we stupid enough to use methotrexate? It kills everything, right? So what happens, we use chemotherapy we literally try to kill everything and hope that the body is strong enough to survive it and the cancer cells die, but the rest of the cells don't. Again, this is great for now. Maybe it was great for 50 years ago, but 50 years from now, forget it. Enter the sort of world of targeted therapy, which was not that long ago, where somebody first found, hey, what if I don't whack out the entire body? What if I find the one chromosomal abnormality that might be causing this? CML, chronic myeloid leukemia, is due to Philadelphia chromosome. How many of you guys have heard of the Philadelphia chromosome? That must have come up somewhere in some class. There's this BCR-ABL mutation. And the cool thing about BCR-ABL is Abelson was the dean of my med school. So not too long ago, like, me and him are hanging out. He discovers ABL. Somebody discovers BCR. They realize that that's what's causing some of these issues. And Drucker, out in Ohio State, Oregon State, realizes that, hey, what if I could target this? And he finds a medication to target it. And this is one of the true breakthroughs in chemotherapy or anti-cancer drugs. All of a sudden, patients with CML cured without side effects because this thing targets the chromosomal abnormality. This was one of the first sort of anti-cancer drugs. But what's going to happen tomorrow? We are just at like the cusp of this, right? Nobody here has had their genome sequenced, correct? 10 years from now, you sit in this room, everybody will have had their genome sequenced. The way that we're able to do this now is so much stronger than the way we were able to do it 10 years ago, 20 years ago, or today. Now imagine if you have your entire genome sequenced, then we know exactly what to target, and maybe we have a drug for it, right? It's going to be incredible. For those of you guys who have some free time to read a book, I really recommend this book. It's called The Emperor of All Maladies by Siddharth Mukherjee. He's a surgical oncologist. It's a great book if you are interested at all in the history of cancer and how any of these things are treated and will be treated tomorrow. Other huge leaps like vaccinations. Jenner was the first person to inoculate and realize that, you could cure people or you could stop people from getting smallpox. For about 200 years, all we did was that, right? We injected tiny little doses of something and hoped that the immune system would kick in. So the next time you got that thing, you were okay. Enter COVID, mRNA vaccines. Now all of a sudden we can do it completely differently, right? You don't have to actually give anybody the virus. You can do something completely different. You can program the cell to actually give your immune response. That's game changing, right? I bring this up. 1922 was the discovery of insulin, right? Before this, kids with type 1 diabetes would die. Age 5, age 6, age 7, age 10, death sentence, right? Type 1 diabetes. All of a sudden you have a discovery of insulin, people can live. I bring this up in particular, though, is because I'm talking about all these really interesting things that are happening in medicine. Insulin, 1922, 100 years ago. Have you guys been following what's going on with Eli Lilly right now? Maybe listen to Biden's State of the Union a couple of weeks ago. What's he talking about? He's talking about insulin prices, right? He's talking about insulin prices because even a drug that was discovered 100 years ago today is unaffordable to a whole lot of people. We'll talk about this a little bit more in a second. But think about that, right? That advances in medicine and science might only be one aspect of what it's going to take to improve health. I bring up stem cell therapy because I think of stem cells a lot like maybe people thought about anatomy back in the day, right? So there's a lot of, remember we talked about cadavers being very, it was sort of evil. You couldn't do a cadaver dissection. You couldn't take a dead body and start dissecting it and looking at it. And that halted progress in medicine for years. Well, we also have a halt in progress maybe in stem cells, right? Because there are factions that are like, well, you can't you can't use embryonic stem cells. That's life. You can't study those, right? You can't use them. I'm not saying that's right or wrong, but I'm saying that is what happens. And now all of a sudden you have less stem lines to study, and maybe that pushes back, stem cell therapy for years. So it's not all science. Some of it's politics. Some of it's capitalism. There's a whole bunch of things that will maybe hold us back or move us forward. I throw this in there because it's just interesting. 100 years ago, 140 years ago, you could get into med school whenever you wanted. Then all of a sudden starts becoming competitive. Hopkins was probably the first one that started this like, hey, you need to do X, Y, or Z before you get into med school. And now you guys need to do a lot before you get into med school. So what will happen tomorrow, right? And what's cool is that you guys are all going to be a key part of this, right? These are just a few things that I thought off the top of my head that I think will change the next 10, 15 years, right? How many of you guys have Apple Watches? Only a bunch of you, right? It's like, takes your heart rate, takes your pulse ox. That's today for a commercially available product from a company. We're not far off from being able to monitor every single thing that's going on inside your body at any given time. Imagine the information you'll be able to give your doctor, or the information your doctor might be able to download on you. I'm no longer doing an EKG for a point in time. I have months worth of data on you. I know exactly when your heart rate spikes. I know exactly what your EKG looks like. I know exactly when your pulse ox goes down. And that's just the start. There's going to be so much more. I cannot see, or I can see a very clear future where maybe we all have health sensors built in, right? Where these things are being monitored so that we know before a stroke happens. Not after the stroke happens and you have symptoms, right? A stroke happens because you have a clot that goes to your brain. Now your brain shuts off and all of a sudden you have a facial droop, or you can't speak. Now I have to go in and remove that clot. You have to get to the hospital. You only have time. Brain is tissue. Your time is tissue. Your brain's starting to die every minute that clot is sitting there, right? So we do things like interventional radiology and interventional neuroradiology do things like catheter-directed thrombolysis. We actually go in through the groin. We take out that clot. But unless we can do that within 30 minutes, your brain's dead. Now, if I have some sort of smart health sensor and I know an hour or two before that's going to happen somehow, it's game-changing, right? Think about the way that maybe I plan for an interventional procedure, or you guys are going to learn anatomy, right? I have a CT scan of a patient, or a brain surgeon has a MRI of the brain, and they can literally sit there with mixed reality and look at it, and all of a sudden start dissecting out things and looking at the flaps that they might use and looking at the planes that they might dissect in, and practice beforehand, right? This is a reality right now. A couple of weeks ago, one of the vendors came in and showed me this for a spine surgery. I do something called a kyphoplasty a lot, where I go in and inject cement into the vertebral bodies for broken vertebral bodies. And they had the CT scan, they had me put on this thing, And in one corner, I could watch the patient. In the other corner, I saw the CT scan. Now, I didn't think it was ready for prime time, but it's going to be in the next 5, 10 years. And the way you guys are going to learn anatomy is going to be with this and not necessarily on a cadaver like the way I learned it. And then there's so many things in medicine that, if we get better at robotics, somebody to continuously monitor the patient, imagine how much time is wasted right now with nurses going up to each room, bringing up a medication. I can't tell you the biggest bottleneck in any hospital is staffing. Not technology, it's staffing. It's, can we get this patient down here? No, we don't have enough nurses right now. Why don't we have enough nurses? Well, because the nurses are running around helping the patients, cleaning them up, giving them medication. We're going to be able to automate a lot of that, right, in the next few years. That's going to help us and really change things. I talked a little about genome sequencing and genomics, right? Again, the way that we approach medicine right now is so arcane almost, right? It's like you have a symptom, maybe you have something going on, but I'm not looking at your genome. I'm not looking at what's actually going on, what's wrong, where can we target? But we're going to be able to do that. And we're also going to be able to know that information well ahead of time, right? I told you, I think in 10 years, everybody in this room is going to have their genome sequenced, and I'm going to know exactly what you're at risk for, and exactly maybe when you're going to develop diabetes, or exactly when you're going to develop pancreatic cancer. That's game-changing in terms of how we can approach it. And then AI, right? Our brains cannot compute what AI can do potentially in the next few years, but imagine feeding all the data sets we have of every medication that we've ever given to a patient and seeing what their response is, and letting the computer figure out, well, why did you respond differently than you with the same medication, right? We didn't even think about that 20, 30 years ago. We just said, well, this patient has AML, we're going to treat them the same way. Well, AML is like a very broad term. There's like a million little tiny subsections of that we're only able to understand now, and we'll be able to understand so much further once we have the sort of intelligence to do it, the data science, the big data sets to do so. And so I take you through that sort of little history, and just remember, most of what I just said was in the last 200 years, right? And if you just think about just recorded history, the last 200 years is like barely even a blip on humans' recorded history, right? Barely even a blip. The next 100 years is going to be pretty cool. Medicine's going to be pretty cool. But I hinted at this, right? Talk about all these cool things. Today, you have patients who can't get access to healthcare. Co-payments are too high, so they won't go to their physician. Mental health is not even talked about in many parts of the world. I gave you the story of Gleevec, right? The first targeted gene therapy. When it came out, Novartis, who was the drug maker, said, we're not going to produce this. Why? There wasn't enough profit in it. So you had a potentially game-changing drug that all of a sudden didn't have enough profit, so the drug company was like, we're not going to produce this. The only way they got around that was a lot of lobbying, and then they charged $1 billion for it, and they were okay. But the reality is, right, we have capitalism. I'm not saying it's good or bad, but I'm saying we have it. And so we have insurance companies and drug companies and everything else that are putting profit over patients. That's the reality. And so we have to navigate this, right? And then keep in mind, we're talking about first world. We just talked about Honduras, right? In Honduras, they can't get the most basic things. Forget any of this crap. You think they're going to do genomic tests in Honduras? No. That's wrong, right? We're not making progress necessarily as physicians and doctors if we're not sort of equally able to spread that progress, I think. Even physicians and doctors and scientists themselves, the amount of work, amount of paperwork, the amount of administrative burden that we have is all leading to burnout, right? And that causes less doctors, less motivated people, less smart people to go into medicine. That's a potential problem. And even another problem, I think, I group this generically as selection, right? All of a sudden, if you can start genomic testing, well, can you start genomic testing in utero? Oh, that person, may not be tall. Person may not be smart. Can you start genomic testing before utero? Oh, I don't want to procreate because I'm not going to I'm not going to have a blue-eyed, blonde child. Wasn't that long ago that was talked about, right? And we literally had mass homicides because of it. Well, in the future, what if we implement this incorrectly, right? Not everybody all of a sudden has all the best interests in mind. It could be a problem. So anyway, as you guys think about this, right, I want to challenge you guys to think about what's next, right? How will you all shape next as the future physicians? And how will we avoid the worst and assure the best, right? How do we get access to everybody? How do we make sure it doesn't fall into the wrong hands? How do we make sure that we continue to make progress along with medicine? So hopefully that gives you a little bit of a history of medicine. I don't know how many of you guys think about this. I love this stuff because I think it's actually kind of cool. And I go back to really saying that I think we're all going to look back 50 years from now and say, wow, that was really stupid. The way we treated that disease was incredibly stupid. I can't believe they were doing that. That's the reality. But you guys get to be part of, hopefully, the next generation that is doing things that are super cool. And again, I think it's just going to accelerate so much in the next 20, 30 years. And that's in the middle of your guys' career, right? It's going to take you 10 years to actually become a physician, if not more. About 15, 20 years, you're going to be in the middle of your career. You're going to be in the middle of something really, really, really cool. The way that we're treating disease now is not going to be the way that we're going to treat it in 15, 20 years, and you guys are all going to be part of that. So I've enjoyed talking to all of you guys today. I hope you guys have found this helpful. Again, if you guys can help us out, leave some reviews. That's actually super helpful. We'd love to come back, love to talk to you guys again. And that's all I got. Any questions on it? Yeah.
With like new emergent technologies and artificial intelligence, is there a possibility that any specialties start to get phased out in favor of like automation?
It's a good question. It's one that I think a lot of specialties are potentially worried about, right? I think it would be naive to say that no specialty is going to go away or no doctor is not going to be impacted by the way we do things, by the way artificial intelligence is going to expand, right? That said, in at least the very near term, nobody's all of a sudden getting artificial intelligence instead of a doctor. What it's going to be instead is it's going to help that physician do better at what they do. Two biggest fields for this, or three biggest fields for this, maybe one, pathology, two, radiology, three, oncology. Oncology, because all of a sudden that artificial intelligence may be able to understand massive data sets that we can't do today. Sometimes oncology trials and the drugs that we use today are based on 20 patients. 20 patients. And all of a sudden we decide that that's what we're going to do. If we do better, if we can feed in big data sets, now we're going to be doing that over millions of patients and really deciding what to do. Radiology is a lot about repetition and understanding and finding little tiny findings. Artificial intelligence models definitely will help there. It won't tell us necessarily what's wrong in the next 10, 20 years, but it might point us to, hey, radiologist, did you take a look at this thing over here? Right? I circled it, me, artificial intelligence. I circled it because I think there's something wrong here. Maybe take your eyes and look at it. What happens after that? I don't know. But I think, the rate at which AI is going to take off in the next few years is certainly going to change a whole bunch of things, including some specialties in medicine.
Actually, I have two questions. So in the beginning, you show like a little art painting, and I kind of know a little context about that painting. It's in the 1630 by Rembrandt. Yeah, the anatomy lesson. So basically, I would call it a dark phase. There's a dark phase in medicine. Even the anatomy book by Leonardo da Vinci was, there's some suspect that there was tomb robbery and then, like cadaver use basically. So I would call it kind of like a dark phase of medicine. Do you think there will be another dark phase of medicine in the future? And second question, how important is medical history for med school?
Okay, let me answer the second question first. I think medical history is super important to keep in context for any physician. And I think the physicians that don't keep it in context, and I know a ton of them, are sometimes too arrogant and don't realize that. I think you learn from history, right? Like that's the main thing that we do. We learn from history. And sometimes they think like, okay, what I'm doing today is definitely right, 100%, no questions about it. That's my dogma. And they don't. If you don't have that context of like, hey, that's the same thing the dude thought 50 years ago, and that's the same thing Halstead thought 100 years ago. If you don't have that context, then sometimes you get like warped into like 100% thinking that exactly what you're doing is right. I'm not saying that they're doing anything wrong, but what I am saying is like it's nice to have that context of understanding that, in the past, people probably thought exactly the same, and in the future, they may not. Now, are we going into a dark age of medicine? I don't know. It seems like we're going to a dark age of humanity to me, but we'll see about where medicine falls into that. That's a pretty loaded question, but I think that hopefully we're going into a bright age of medicine with a whole bunch of understanding and knowledge that we have never had before. Other questions? Yeah.
I have a question relating to your first talk earlier. So I know it's becoming more common to take gap years instead of going straight to medical school. Do you have a recommendation of one versus the other?
That's the context of your application, right? So I think I was talking to somebody early. Do you know what the average matriculant age to medical school is? 25 to 26, which means that the average person is taking 2-3 years off, right? At University of Massachusetts Medical School in 2022, 97% of the class or so took a year off. So the commonality almost is becoming taking some time off to either improve your application, to do something that's more interesting, to make sure you're ready for medical school. Now, I'm not saying you have to by any means, but if your application is sort of on the cusp and you could benefit from a gap year, you're going to benefit from it, right? You're going to do all these things that hopefully will make your application better. And medical schools are very, very much looking forward to people who have additional experiences for their incoming class. Anybody have thoughts? Any other thoughts? We've turned this into a philosophy class or a history class. Yeah.
What potential new entire fields, subfields do you think might come about in the next 30 years because of the leaps in diagnostic or other technology that
I think what you're going to see is we've always gone to this route of specialization, right? People specialize in an organ. Right now it's very organ specific. You're a urologist who specializes in the genitourinary system. You're a nephrologist who specializes in the kidney. I think what's going to happen is that something like oncology is going to become so specialized, right? We talk about cancer as this like catch-all, but every cancer is so unique that you're going to have specialists even within oncology that break apart, right? And so I guess I don't have a crystal ball on which specialties evolve or come to be, but I do think that there will be further subspecialization in terms of, maybe there's a specialty called, there is already genomic medicine, but like really genomic medicine, like somebody who's out there understanding how to interpret this data, right? Because, by the way, we have all this data. We have more data than ever even today, and we have trouble interpreting it. What happens in 20 years when the amount of data we have is exponentially more than what we have today? Somebody's going to have to figure out how to interpret that and understand it in the context of medicine better. Maybe that's a specialty that comes up.
going off of what you just said, do you think it might become a more necessary, I guess, foundational skill for just being almost a good data scientist if you're a physician, being able to understand?
Yeah. I mean, I think that there's no doubt that if you can understand that, you're going to be a lot further along in years to come, right? That's probably true of a lot of things, right? Think about the way that maybe, people of my age, the ones who maybe understood engineering or computers or computer science better than some others, maybe had an advantage in some ways in understanding or interpreting or even just simply working with the damn OMRs or the EMRs, which are horrible, right? Like I can do it a lot faster than some of my colleagues because I'm pretty adept at computers. They're adept at other things that they can do better. But I think in the years to come, I think if you do have a background in data science and understanding how to put these together or understanding how to interpret these, you probably will be at an advantage in some specialties or be a better doctor in some areas. Not like, of course, being a doctor involves a whole lot more than just interpreting data. The best doctors are the ones who make the best connections with patients. But all these things could put you at a advantage, or maybe your skill set is best utilized there, right? Even today, like the way, I'm an engineer by training, and I think the way that I approach things is very different than the way some of my colleagues approach things in terms of the mechanical issues that might be caused. So anyway, I think any background you have is going to be helpful. I definitely do think that the background in sort of data science, big data, understanding that will be really helpful, particularly for some fields like oncology in the future. Yeah.
With all the advances and kind of just really high technical things that are going on around us, how do we as like pre-meds or even medical students later on, how do we kind of get connected to that or be involved in that in a good way?
Yeah, so there's a ton of things that I think, so first of all, you're not going to be able to evolve in everything. You're not going to be able to understand everything. But I think that, this is where some of the research components come in, right? If you can hook up with a PI who's doing some research in some of these areas, it might give you a leg up. I think even just having an understanding of this stuff is important, right? So for those of you guys who didn't know about the pig heart, that's a pretty simple, that's in the New York Times, right? Read about it. And don't just read about it in the New York Times. You guys are all pre-meds. Go find the next sort of more advanced thing to read about. And that doesn't mean you read about it in the New England Journal, because that might be too advanced. But there's something in between, right? There's something in between the layperson and the extremely technical stuff that you guys as pre-meds can get a handle on and be like, wow, that is interesting. Let me dig in a little bit more on that. And by the way, when you go sit down in an interview with somebody for medical school, that's the kind of stuff that we want to hear. That's the kind of stuff that we want to talk about with you, and it would be interesting. So I think anytime you find something that's interesting, dive a little deeper, right? At the very least, know what's going on in the lay literature and the lay people, right? The lay press, New York Times, all those kind of publications, and then try to go a little further as a pre-med to gain some more exposure. And then when you find the thing that you like, go find a research PI who's doing it, right? And go sit down in their lab and try to get some work done with them. Maybe that's how I would approach it. All right, guys. Thank you again for coming out today. I know we had a little bit of dwindling here, but hopefully it was helpful. Hopefully it was cool. Good luck for all of you guys as you guys are going along this journey. As you can see, I'm sort of passionate about it. I love what I do. That's why I still practice clinical medicine. I just love going into hospital and doing what I do on an everyday basis. And I hope you guys all get to that point too. Obviously, to get there, you got to take the MCAT, you got to get into med school. We can help you with that. You got to pay for med school. We can figure out ways to help you with that too. So if you guys ever need any help, reach out to us. We're at medschoolcoach.com. But thanks again for having us, and this is great to be here.